Welcome back to Catalyst University. My name is Kevin Tokoff. Please make sure to like this video and subscribe to my channel for future videos and notifications. And a big thank you to my patrons on Patreon for your contributions to my channel. This video is going to be all about kidney disease. We're going to start off by talking about the pathogenesis of kidney disease, and then at the end, we'll go into the staging of kidney disease, and we'll see that there's exactly 5 stages. But let's first talk about some of the normal things that a healthy kidney will do. The first is the production and release of this hormone called erythropoietin, usually abbreviated EPO. Erythropoietin will act at the red bone marrow in certain bones and stimulate a process called hematopoiesis, which by the way is exactly the same as hemopoiesis. And this leads to the production of more erythrocytes, or red blood cells. So it turns out in the kidneys there are certain cells that are oxygen sensors, or O2 sensors. And so when oxygen is low in the blood, they sense that and trigger the production of more red blood cells. The second thing that the kidneys do, and this is probably the function that you're used to hearing about most often, is they're involved in the regulation of fluid balance. So in a healthy person, if fluid volume or blood volume is low, they will enact mechanisms to raise the blood volume, which should in turn correct blood pressure. Okay? And if blood volume is high, they help with excretion of excess water to bring the blood volume back down, and also normalizing blood pressure in that way. And hopefully you know at this point that they're acting through the RAS system, renin-angiotensin-aldosterone system, in order to do this. And if you need more detail on that, I have a separate video which I will attempt to link in the description of this video. Now, in chronic kidney disease, there's a decreased number of nephrons. This was a question from Anatomy and Physiology all the way back. What is the functional unit of the kidney? And the answer is the nephron. In kidney disease, there's a reduced nephron number. And so with less nephrons, there's less ability to filter the blood and get rid of bad stuff, right? Now, initially in chronic kidney disease, so early stages, when there's a reduced nephron number, the kidneys are going to attempt to compensate for less nephrons. And they're going to have what's called adaptive hyperfiltration, specifically at the glomerulus. Recall that the glomerulus is this cluster of blood vessels right here, part of the nephron, and that's the specific part that filters the blood. You can see it right here. And so what this means is that if there's less nephrons, you've got to increase the filtration by each individual nephron. So that's what this adaptive hyperfiltration is. It's an attempt to maintain the same level of filtration, the same filtration rate. This adaptive hyperfiltration is associated with 2 things. One is this increase in glomerular permeability. Remember, each glomerulus are just capillaries, right? So they have a certain permeability that allows things across their walls. And so we get an increased permeability. This is part of that compensatory mechanism. We've got less nephrons. We need more filtration per each nephron. The way we get more filtration or hyperfiltration is increase the permeability at each individual glomerulus, right? And we'll come back to this toward the end of the video. The second thing that happens here is a chronic and excessive activation of the RAS system. So we're going to see too much renin, too much angiotensin II, and there will also be too much aldosterone. And there's really 2 mechanisms that play a role in this excessive RAS activation. One is just the chronic kidney disease, and the other is actually a deficiency of vitamin D. Let's actually briefly understand that. So here's a short metabolic pathway. We've got here 7-dehydrocholesterol. This is an intermediate and one of the final intermediates in cholesterol biosynthesis. Okay? You can actually see that the structure here looks very similar to cholesterol. In fact, there's just one enzyme needed to convert 7-dehydrocholesterol into cholesterol. Now, some of the 7-dehydrocholesterol is always going to be converted to cholesterol. However, some of that 7-dehydrocholesterol will move through a pathway to make vitamin D. So the first reaction here converts 7-dehydrocholesterol into what we call pre-vitamin D. This is actually not an enzymatic reaction. It actually requires light from the sun at a wavelength between 290 and 315 nanometers. This is why you need to get your sunlight so you can get vitamin D. And then pre-vitamin D3 is converted to cholecalciferol just by heat. Again, a non-enzymatic reaction. Now, cholecalciferol will be converted into calcidiol by the action of 25-hydroxylase. Calcidiol is also called 25-hydroxy-cholecalciferol. This is a reaction that occurs in the liver. Now, the final reaction is catalyzed by an enzyme in the kidneys. This is called 1-hydroxylase, and it hydroxylates this molecule again to form what's called calcitriol or calcitriol, some people pronounce it, which is really just 1,25-dihydroxycholecalciferol. Now, this calcitriol, or active vitamin D, is going to act at the vitamin D receptor to promote several different things. One would be anti-inflammation, okay, so it reduces the degree of inflammation within the body. It helps to balance lipid levels in the serum, so triglycerides, lipoproteins of different kinds. And then it also helps to sensitize cells to insulin, right, which is the opposite of insulin resistance. Now, why do I show you all this? To help you understand that the kidneys are absolutely necessary for the full activation of vitamin D. Sunlight is necessary, but it's not enough. You have to have functional kidneys in order to perform this final reaction and to get these three effects over here, which are also necessary for healthy kidneys. What happens if we have kidney disease? Well, we have less of this enzyme over here, 1-hydroxylase, and so there will be less conversion of calcidiol to calcitriol or calcitriol, and so there's less active vitamin D. What would that cause? Well, there's less vitamin D, so now we have the opposites of all those things. We get more insulin resistance, so decreased peripheral sensitivity to insulin, more inflammation, and dyslipidemia. And really all three of these things lead to further kidney damage. And so with continued kidney damage, we can really say that a deficiency of this calcitriol is going to lead to hypersecretion of renin and hyperactivation of the RAS system. So there's really two things that do this. One is just directly that decreased nephron number. This is a compensatory reaction. But with damaged kidneys, there's less vitamin D, and so because we get more inflammation as a result of that, we're going to have more activation of the RAS system. So more on the RAS system. So we get excessive renin, excessive RAS, excessive angiotensin II, not shown here, but we also get excessive aldosterone, and all of those things are going to cause fluid retention. Remember, renin is normally released in a healthy individual when blood volume is low. It's designed to bring blood pressure back up and blood volume back up. But now we're getting an abnormally high release of renin at an abnormal time. So we're getting more fluid retention and overall impaired blood volume regulation, and so this is going to cause more fluid in the body, and in order to compensate for pumping that fluid throughout the body, there's going to be structural changes at the heart, and so we're going to see left ventricular hypertrophy as one of the main things. And it's important to know that with chronic kidney disease, the number one cause of mortality is actually cardiovascular disease. You don't actually die as a result of the failed kidney. You actually result of something secondary to that, like cardiovascular disease, because of this hypertrophy of the left ventricle. And so some things that you might see as this disease progresses more and more would be chest pain, nausea, shortness of breath, and sweating. Also note that in kidney disease, we're going to have less erythropoietin release, and so as a result, less hematopoiesis and less red blood cell production. And so this will often manifest in patients with kidney disease as anemia. Now, some other effects of chronic kidney disease are going to manifest usually in three major systems. One is the GI, the second is musculoskeletal, and then the last would be neurologic. So the GI issues are going to be nausea, vomiting, anorexia, malnutrition, and as a result of the malnutrition, fatigue and muscle weakness, and then there also might be malaise. With MSK issues, these are mainly going to result from impaired metabolism of several ions and other molecules like calcium, phosphate, and we talked about vitamin D metabolism already. Calcium and phosphate are, of course, necessary for the structure of bone, and so if these are deficient because the kidneys aren't working, it often results in renal osteodystrophy, which basically is bone weakness that causes bone pain and can result in fractures. You can also see calcification of soft tissues like the Achilles tendon, and you might have tendon rupture as a result of that. And even calcification of vessels, which could impact things like coronary artery disease, and if they rupture, then you could have a heart attack. Remember, cardiovascular disease is the number one cause of mortality in chronic kidney disease. And then neurologic issues, so sleep disturbances, uremic encephalopathy. This will occur when the glomerular filtration rate drops below 10 milliliters per minute. To put this in perspective, the normal GFR is 120 mils per minute. So 10 is very low. So this will not be in every single patient. It's only once it drops really below 10, which is extremely low. But you can also have memory loss, confusion, perceptual errors, decreased alertness, and really all of these things, regardless of the system, become more apparent and more prevalent as you progress through the stages of chronic kidney disease. And that leads us to the stages of chronic kidney disease. So to understand this, let's first look at a healthy kidney. So a healthy kidney is normally going to have a GFR of about 120 mils per minute. So this is an average value, and as we age, it does naturally decline a little bit, but it'll probably stay around 110 to 130 mils per minute. This is just an average value. So now for the stages. There's 5 stages, and the first 4 we typically would term stage 1 chronic kidney disease, stage 4 chronic kidney disease. When we get to stage 5, we now start calling it end-stage renal disease, and it has a very high mortality rate. Now in stage 1 chronic kidney disease, the GFR is still going to be at least 90, so we're probably looking at a GFR anywhere between 90 and 100 mils per minute. These patients will often be asymptomatic. They will display no signs or symptoms other than a decreased GFR that they have chronic kidney disease. Okay? It's not until we get to stage 2 that we start seeing some signs and symptoms. So in stage 2, the GFR is going to be about 60 to 89 mils per minute. Now, as we get more into chronic kidney disease, we're going to start to see some proteins in the blood. However, at this point, they're very small proteins, and the main protein is albumin. This is a protein that's normally responsible for transporting lipids in the blood, like fatty acids and other things like drugs. And so albumin will start to appear in the urine. There also may be some hypertension and also some anemia. Remember that the kidneys produce EPO, and so we may start seeing a drop in red blood cells at stage 2. In stage 3, the GFR is markedly dropped, down between 30 and 59 mils per minute. So now it's less than half of the normal value. And here we're going to see even more albumin in the urine than we saw in stage 2, and we'll also see decreased albumin in the blood as well. We'll also see an increased blood urea nitrogen and creatinine level in the blood as well. In stage 4 chronic kidney disease, now the GFR is 15 to 29 mils per minute, and at this point, we're going to see a lot of this protein urea. Remember this figure? When we have a decreased nephron number, we've got to compensate somehow. One of those was increasing glomerular permeability. And at some point in kidney disease, the glomeruli become so permeable that they're actually able to filter large proteins. Okay, and this leads to that proteinuria, which we see in stage 4. So there's a lot of proteinuria, a lot of proteins in the urine at this stage. Now the last stage you could call stage 5 chronic kidney disease, but it's often called end-stage renal disease. At this point, the GFR has now dropped below 15 mils a minute, and we start to see uremic encephalopathy, particularly when the GFR drops below 10 mils a minute. So are you going to see this encephalopathy in someone with stage 2 and 3? No, because it takes a GFR that's pretty darn low to start to see those neurological changes. And as I mentioned before, end-stage renal disease has a very high mortality rate and often necessitates a kidney transplant. And as we progress from chronic kidney disease to the end stages, we're going to see a lot of changes. One is that increased angiotensin II release. Remember, we get excessive activation of that RAS pathway, and as we go through stages 1 to 5, you get more and more activation of that pathway. Same thing with GFR. It's going to be reduced more and more as we progress through the stages, starting from 120 being normal to less than 15 by the time you're at end stage. Also, the glomeruli not only are reduced in number because of the nephron damage, they're also going to become fibrotic and sclerosed. So those capillaries are not going to be compliant, they're going to be scarred. And also, because of that angiotensin II release, we're going to have severe constriction at the glomerulus. Also remember that angiotensin II has actions elsewhere in the cardiovascular system. It can vasoconstrict all sorts of arterioles all over the body. And so not only are we seeing effects here at the kidneys, but there's vasoconstriction everywhere, which is also really bad because the heart is also overworked. As we talked about, you get that left ventricular hypertrophy. And what do you often die of with chronic kidney disease? Cardiovascular disease. It is the #1 killer with diseased kidneys. So hopefully this video gave you a good understanding of the pathogenesis of chronic kidney disease and also the staging of it as well. Thanks for tuning in. Please like, subscribe, and check out my Instagram for cool science and not science stuff.